ScvO2 central or mixed venous, no, nobody now the very bad time for the Schwann-Ganz catheter, and so basically we refer on central venous. I think the Schwann-Ganz catheter still has his role. Anyway, SvO2. What it is and where to sample is quite clear. Let's see. Normally we have an amount of oxygen per minute put to the periphery for about 1 liter if we have a normal hemoglobin and normal saturation, normal cardiac output. Of this 1 liter, 1/4, 1/5 is sucked by the tissue. So the amount of oxygen remaining back to the central, to the heart, is 1 minus the oxygen sucked divide the oxygen offered. So the venous saturation is nothing else than the balance between what has been offered and what has been consumed. As what has been offered depends on hemoglobin, depends on oxygen saturation, and depends on cardiac output, it clearly comes out that mixed venous saturation is the best monitor that you can have in a desert island when you have only one monitor available. Because when this change means that either you have lung problem, either you have VO2 problem, maybe high fever, maybe is the cardiac output which is increased or decreased. So the ratio changes, or you have a problem with hemoglobin. Sometimes I had one patient going down quite rapidly was because of gastric hemorrhage. This was the only sign was the saturation at the time when we were measuring continuously the SvO2. So the SvO2 is very aspecific, doesn't tell you what it is, but tell you that something is wrong. So sit down, connect the brain, and check. But this tells you immediately that something dramatically wrong may happen. This is what's I think, so important. But this is the meaning of the SvO2. Then, what is the relative weight? Let's see. If I decrease the oxygen consumption, I start with normal oxygen consumption, 250, 80% of SvO2. If I decrease 10%, that gives you 10%, 20%, 30%. I change the oxygen consumption. This tells you how much change the SvO2 goes up. And this happens when you have a decrease of hemoglobin. And this happens, and the decrease of hemoglobin is exactly numerically in percent as the decrease in cardiac output. And then this is what decreases the saturation. And you have the linear relationship. So when you read a paper saying, we had a lot of funny papers saying, okay, how much the SvO2 relates to the cardiac output, doesn't mean anything. SvO2 changes with cardiac output according to a very precise relationship, but is not an indicator of the cardiac output alone. May be the cardiac output, but may be hemoglobin, may be saturation, may be oxygen consumption, and so on. Of course, having this central part is quite obvious. We do not require randomized study or great effort to understand that if we have lower PCO2 is associated with a greater mortality. A patient with SvO2 of 50, 60 is not so happy as with a patient with a normal CO2, because the normal SvO2 is a needle of that tell us in the safe limit in we're running. Is the site is important? We have in the 80s a lot of discussion about that. because in the 70s and the 80s, all the focus was on the physiology. So our generation grew up with the physiology. I think from a clinical point of view, of course, the central venous is not the same thing as the mixed venous. But for practical purposes and for looking at the changes, I think they are decently correlated. I say decently, and not perfectly correlated. So if you want to use the FIC, reverse FIC for oxygen consumption and so on, you have to pay some attention. But from a clinical purposes, when the central venous CO2 changes, something important may happen. And this, what indicates really a normal CO2? This is a study that we did targeting to SvO2 of 70, or the supranormal values or normal cardiac index of 2.5. This 10 years before Rivers, and was very clear that if you target the meaning of 70 of SvO2 has to have, in general way, a cardiac index normal, around 2.5. So when you have 70% of cardiac of SvO2, you know that the cardiac index is adequate and is usually in the normal range. So this is the general meaning of the SvO2. Now, what's happened? It is lower, or when which is higher. When it's lower, it's quite easy to understand. So we may discuss a little bit of SvO2 as a monitor, as a target, and as a tool. As a monitor, depends, as an example, I try, when I had the responsibility in Milan for years, to prohibit to have any arterial blood sample without the venous blood sample. I didn't succeed, of course, because the people love to take the arterial blood. But if you have the pulse oximeter that tell you more or less the oxygenation status, and you have the central venous blood, you have the same information for what here the PCO2 is concerned. You decrease the venous of about 3, 4, 5 millimeters of mercury, you have an idea of the arterial PCO2. The base excess is 1.5 as a default, greater in the venous blood than in arterial blood, because the biocarbonate is different, the pH is different. I don't have time to get into this problem. But this is just to say that if you have a venous blood, a central venous blood, you have the same information of the arterial, if you have also the pulse oximetry, and more you have this one, which reflects the job of the intensive care doctor, which is to maintain the homeostasis. And the most important homeostatic points are summarized in the SvO2. So, lower SvO2, cardiac output, VO2, hemoglobin, oxygenation, acidosis. Be careful, because if I have a strong acidosis, for the same content of oxygen, the balance between free oxygen and bound oxygen changes. This is called the shift on the right or on the left, depends on the pH, of the hemoglobin dissociation curve. It's nothing else that for the same content, the hemoglobin release more oxygen out or keep more oxygen bounded. So all this information are reflected by SvO2 changes. And this is why I think is so important. And when it's higher, this is more complicated, because we have not less data, we have less clear idea of what's going on. Of course, we may have severe alkalosis. For the same PO2, we have severe alkalosis, maybe we have higher, but it's not so common. Severe alkalosis is said. Hypercinetic circulation dissociated from oxygen consumption. So an excess of circulation compared to oxygen consumption, which is possible. And then we may have the peripheral shunt, has to do with the microcirculation. That means at the microcirculation I shift the blood, or I have a mitochondrial dysfunction. Excuse me, these two cannot be distinguished with SvO2. You have exactly the same effect. And we do not know how are really important. But this, as an example, is one of the classical findings of some early phase of the septic shock. So also in this case, if you have 85% of SvO2, you are not happy. You are not happy. Maybe you are happy. The patient is not happy. Okay. Now, as a target, long discussion, we couldn't find any difference between supranormal value, oxygen saturation group, or a control group where we target SvO2 at the 70. This study was done in 95, past a century. Then come out the paper of River, very discussed, but look at the River paper, the control baseline SvO2 was 49 and 48. In intensive care, when you receive the patient, usually you don't have this SvO2. I don't remember really to have seen many times. I don't remember too many times so low SvO2. So, randomized trial. Randomized trial, what they show? They took a patient with normal CO2, or normal SvO2, most of them with a normal PVCO2, and they targeted to the normal SvO2. What do you expect? Of course, we have absolutely identical results. And of course, if you take 3 identical results and you do the meta-analysis, you may be surprised, but we will get again an identical results, which is great. But the problem of this funny paper is that the people say, well, these were target SvO2, so the SvO2 is garbage. Who cares about SvO2? And this is a wrong, absolutely. I'm not speaking about the target, but the SvO2 as a monitor. And even target, I prefer to have, whatever we do tends to have the better patient. The better patient at better SvO2. You can turn the cards as you like on the table, but the results at the end are the same. If you do the right thing, the SvO2 does not go down, goes up if it's low. It's quite simple. So, and my last minute, save values as a tool. This is my slide. We discussed for 30 years how to set in PEEP. And now, in the last 10 years, about a few centers, the hemodynamic have been completely forgotten. Well, SvO2, if you have the central venous CO2 and you want to do a PEEP test, it comes out very, very easy. If you have the saturation goes up and the PaCO2 goes up, that means the alveolar ventilation, there is some problem, because exists also the PCO2, not only the PaO2. And then look at the saturation here. If the saturation in oxygen goes down, increasing PEEP, and this is very bad. That means this is not good. The PaCO2 in this contest goes up and goes down. So this, just to tell you one thing, just summarize the complicated slide. If you have an oxygen and a PEEP test, you increase the PEEP and you look at the venous saturation. If the arterial saturation goes up and the venous saturation goes up, we are very happy. If the arterial goes up and the saturation venous stay there, you are happy, but you know that you are probably at the limit. If one goes up and the other one goes down, it's very bad. And look also the PCO2. So it's a very simple tool, is one of the practical applications of ScvO2. But to me, ScvO2, the great importance is still as a monitor. And I thank you for the attention.